I think it's actually the radiator in there expanding and contracting. Is it? Yeah. Check it out.
We're live.
We're live. Well, it is 10:01. I'll call the meeting to order. Madam recording secretary, is that? I want to say clerk, but you. Anyway, Kaylee, would you take the roll call, please?
Yes, I can. Good morning, everyone. Dr. Era,
Present.
Chris Peabody,
Present.
Helen Claire Tingling,
Good morning, everyone.
Sue Patterson,
Present.
Nick Saunders,
Present.
Dr. Zayed,
Present.
Kenneth Craig,
Present.
Warden Milne,
Present.
Luke Charbonneau,
Here.
Ian Body and Alan Barfoot send their regrets. Kevin Eccles. Kevin Eccles.
Do we have forum? Excellent. Are there any amendments to the agenda? Ken?
Yes, please, regarding correspondence 6.1.5. I'd like to make an addition to the agenda regarding a resolution for disclosure in that matter.
Okay, thank you. So you're okay doing that at 6.1.5?
Yeah.
Okay, good. Any other? Not seeing any. Can someone please indicate they'll move the agenda as amended? Luke, seconded by Helen Claire. Any further discussion? All those in favor? That is carried. Thank you very much. Is there any disclosure of pecuniary interest related to any item on the agenda? Not seeing any. If one should arise through the course of the meeting, feel free to do that. Adoption of the minutes of our last meeting, which was Friday, March 3rd. Someone please move adoption of those minutes. Luke, seconded by Sue. Any discussion? All those in favor? That is carried. Thank you. Correspondence. Better make use of Kaylee's binder here. She was gracious enough to make all this for us. Who goes through? Does Dr. Era go through these? Yeah, okay. Dr. Era?
Thank you, Mr. Chair. We have 5 correspondences. 3 of them are from the Peterborough Public Health, and they're related to the improvement of indoor air quality or efforts to improve it. One of the correspondence, the one correspondence is to the federal government, the other one is to the provincial government, and the third one to the Ministry of Labor, Immigration, Training and Skills Development. All correspondences have the same goal, as I mentioned, urging the government to improve air quality through different measures. The recommendation there is to receive. The 4th correspondence is the Chief Medical Officer of Health Annual Report. According to the Health Promotion Protection Act, the Section 81, subsection 4, the Chief MOH will produce an annual report, and I believe the annual report that was produced this year has been significant on many fronts, mainly urging the government and different partners to ensure preparedness for outbreaks and pandemics for the long run. And another message in the report itself is ensure funding for public health sector, local and provincial, and to end the boom and bust cycle as explained in the report, which relate to the history of public health, where it is well funded after crises or pandemic or public health issues of significance, and in few years the funding will be tapered down or discontinued. So it is a significant report. It is for receipt as well as recommendation. The final correspondence is a report from the Ontario Ombudsman, and in its conclusion, the May 10th and 12th meetings in 2021 were appropriately closed as discussions fit within expectations to the Municipal Act, open meeting rules and closed meeting rules. And the recommendation is to the Board of Health to remain vigilant and adherent to their individual and collective obligation while ensuring that the board complies with its responsibilities under the Municipal Act. Again, the recommendation or the direction from the Ombudsman Act was to publish this report, make it available publicly in the first available public meeting for the board, and that is today. We received it less than 10 days ago, I believe, and the recommendation is to receive open to questions as always, Mr. Chair.
Thank you, Dr. Era. Are there any questions from board members regarding any of that correspondence? Ken, you wanted to speak to the last item there?
Thank you, through you, Chair. As Dr. Era has commented, the Ombudsman has published this report. And the last bullet, the last number 66 in the report, very end, says this report will be published, as Dr. Era commented, on my office's on the Ombudsman's website, and should be made public in accordance with Section of the Municipal Act. Our board is required to pass a resolution stating how it intends to address this report, and I'm wondering how our staff is recommending that this is being addressed, whether it's through a more widespread publication of this report. Is it continuing education for staff in accordance with the guidelines in the Municipal Act for closed meetings? Is it a governance review of our closed meeting process? I'm just wondering, through you, Chair, how staff is recommending that we actually do address this concern the Ombudsman has raised. Thank you.
Good questions. And I had the verbiage here, but darn if I can find it now.
For the report?
Yeah,
Sorry.
well, no, how we were going to, because we need, as a board, we need to make a statement regarding this report. And Kelly sent me that verbiage and I cannot find it now.
I have
So
it.
you have it?
I do.
Okay,
Would you like me to reiterate?
perhaps read it, please. Which this, and this will be recorded in the minutes as well.
As a board, we strive for transparency, and we are therefore relieved with your assessment that the decision to close the Board of Health meetings of May 10th and 12th, 2021 was appropriate in both instances. Upon review, we understand that we made procedural errors, but we appreciate the recognition that there was no intention to contravene the Municipal Act. In future, we will vigilantly work to strike a better balance between maximizing the information available to the public while not undermining the reason for the public's exclusion.
So that's the statement that we need to publicly declare in regards to the report. If there's further action required or thought needed, then, you know, I'm in the hands of the board, what they'd like to take or what they'd like to do. Ken?
If I may, through you, Chair.
I'll come to Dr. Aaron.
Oh,
Okay, go ahead, Dr.
I appreciate it.
Yeah, thank you, Mr. Chair. Through you, just to answer Ken's question, we reach out to the Ombudsman's office to ask what they mean by publication, whether it's on our website or broader, and their answer was to include it in the board meeting, the public agenda today, and that would be appropriate for publication. Correct me if I'm wrong, Kaylee, you were leading the communication or on my behalf.
That's
Okay.
correct.
Yeah, Ken, is there anything further?
Well, there is, I think, because there is a, for one thing, I was not aware, I'm not sure had that statement been distributed to the board members, which,
No,
so-
it wasn't.
so the word that caught my attention in there was balance,
Mhm.
because the Municipal Act, you know, there's the spirit of the law, but there's also the letter of the
Yeah.
law. And for any organization to maintain its professionalism, I believe that you know, at the highest levels of governance, that that there is a broad spirit, but we really have to be attentive to the letter of the law.
Yeah.
And to that end, maybe it would be helpful for us to either, I've been reading the policies, trying to catch up, and there's quite a mishmash of overlaying, and I appreciated what Ms. Henry had done to put them together and all that, but there's spots in there that I don't even know what I'm supposed to be doing. Outside of just the closed meetings. So whether it's a review of our procedural bylaw, or whether it is, and I don't mean this in any slight at all, continuing education for us and the staff on how to present agendas and the intent of the municipal act for closed sessions. I think that would, part of our role of governance is to know what we're governing and how we're supposed to do it. So I think if we might make a resolution to address policies or something to that effect, I would defer to your guidance in that regard, Chair.
Dr. Yerick?
Yeah, thank you, Mr. Chair. The policies, according to our board bylaws, need to be reviewed every 2 years. And the last time they were reviewed by the executive committee was in 2021, and they will be due for review later in the year. Orientation for the board members is scheduled, and continuous education is definitely key. The recommendation from the Ombudsman's office is to make the report public. Simple as including it in a board agenda. We suggested publishing the report as soon as we received it on our website, and that was not the recommendation. Again, the scope of this item is very clear on the Ombudsman report. I will defer to the executive committee to elaborate on the thorough review of our policies. And it is not the clerk's duty to actually review the policy. The clerk's duty, or the admin for the board and the MOH, not the clerk, sorry, duty is to help us take minutes during that review, and that was done. I would elaborate, or I would add one more point. The policies for the board were reviewed in 2017 and 18 externally, and there was no issue, or whatever was identified there as room for improvement was already done. So again, to the executive committee, that's a main function there, but I am very comfortable that we have top-notch policies there.
Oh, Claire?
Thank you, Mr. Chair. Through you, I greatly appreciate my colleague Ken's comments about not just being the letter of the law, but the spirit of the law. In fact, the Ombuds report stated that that the board was appropriate to go in camera, but that there were 2 procedural errors made. And I'm not as concerned about how we post the report. I think that's being taken care of, but I remain profoundly concerned that we as a board are not necessarily as knowledgeable about the policies, these great policies that we have, and it behooves us. It is a requirement of governance for us to know. So yes, there is orientation. I have spoken at length with the previous board to try to communicate to people that are interested in joining the board that it is a huge commitment to stay up to date, to not just gather what has been done before, but to be committed to stay up to date. And that's the sentiment that I'm receiving from my colleague Ken, and I really am happy to hear it. So to the point about the 2 procedural errors, I believe that we as a board need to spend some time digging in to know what our roles are, to become familiar again or with these policies and procedures, so that we are less likely to make these errors, which were accidents. I have the greatest respect of every single member around this board. Everybody, with the exception of provincial nominees, has been put in place by vote. And that is a huge endorsement from the community. And we have to do our best to step that up, to take those responsibilities seriously. And ongoing education is a way to do that. Finally, the previous chair had made it a habit of having a little education piece at the top for things that were germane to the agenda, things that she could pull up that perhaps people didn't know and would help inform us. And I really encourage the board going forward that we continue that practice. Thank you, Mr. Chair.
Thank you, HC. Okay, Luke, go ahead.
Sure, and I just wanted to make the comments that we have not, so the resolution that was read there, we don't have. I don't think there is a requirement in 66 that we pass a resolution stating how we intend to address the report, but we don't have to pass it today. I wonder if the thing to do would be to have it come back, actually be on the agenda in a month's time, and also to include, as Ken and Helen Claire have talked about, some direction about some education. I think one thing that often happens in the aftermath of an ombudsman's report is closed meeting training for an organization, and that would be a good piece of training that I think certainly it's training I have received before, but it never hurts to receive it again. And I think it might help this organization to get have either the Ombudsman's office or the Integrity Commissioner come in and deliver a couple of hours worth of training about the Municipal Act and the closed meeting sections in the Act. So I think that would be a good way to address this report, as the Ombudsman wants us to do, would be with some training that we can easily get. So I would suggest we bring the resolution back, have it actually on the agenda so we can all see it, and perhaps amend it to include some training specific to the Municipal Act and the closed meeting sections under the Act. So my suggestion, Chair.
Okay. Well, I think the Dr. Eric.
Mr. Chair, thank you. The board bylaw includes annual training for the board members under the acts that we operate under, and which is not the act that we operate under is the Health Promotion Protection Act, is not the Municipal Act. There is some overlap related to the board meetings, definitely related to the Municipal Act, but that is included in the training, and the training that we designed in 2021 is delivered by James Lanori, and the attorney for Alpha, the attorney for public health in Ontario. Top-notch training. It is available for all board members, and it is scheduled annually for the training. I believe it will be in the next months. It's worth mentioning, Mr. Chair, the procedural error, the recommendation from the Ombudsman Office is to include brief wording about the items that are going to go into the in camera in the closed session. And as a matter of fact, this was actually taken care of before the report was received. I believe it was in the September and October of 2022. Mayor Charbonneau pointed out that this is a new practice or required by the Ombudsman's Office. So we adapted it, and we have been, to the best of our ability, providing that extra verbiage on each item without breaking the confidentiality of the item. And our agenda reflects that since October, I believe. And again, that's a procedural error that is minor. The main conclusion in the Ombudsman report is we were in compliance with the Act. Again, I don't see that there is a specific training other than what we provide, but that is my recommendation for the board.
Thank you, Dr. Eric.
I just
Go ahead, Luke.
Mr. Chair, I just have to point out, and with great respect to Dr. Eric, we are indeed subject to the Municipal Act under the closed meeting rules of the Municipal Act. It's all through this report, right? The Ombudsman clearly points out that the Board of Health is subject to the open meeting rules of the Municipal Act, and his letter here is a ruling on that basis. So I strongly believe that it would be very helpful for the board to have training from the IC specific to the open meeting rules under the Municipal Act, because we are subject to those rulings. And I would say that although it is true that in two cases, the board did not convene the Act in terms of talking about things that it shouldn't have been enclosed, there were, it's stated right here, the Board of Health and the executive committee contravened the requirements of certain sections of the act on at least a couple of occasions. There's nothing minor about contravening sections of the act, in my experience. So, and it's not, you know, it's an opportunity, it's not a serious contravention, and we did not intend to contravene the act, and those things are clearly pointed out, but it is a contravention, and I think a little education about the act and its contents would help us avoid stepping in those potholes again. So anyway, I've stated my case on it. I just wanted to clarify those points. Thank you, Mr. Chair.
Okay, before I go to Ken, I'm hesitant to put this off because I think the ombudsman wants to see that we received the report. So I'm wondering if the motion is to receive the report and ask staff to look into providing more training regarding closed meeting procedure to the board. Would something of that nature? Ken? Oh.
Thank you. Through you, Chair. I was noting in the ombudsman report the same comment as Mayor Charbonneau had made in the regards to not comply with the rules of the Municipal Act. And as I was reading policy, the procedure bylaw for the Board of Health indicates that the agenda for the closed meeting can be included in the agenda of the open meeting, which is significantly different than what the Municipal Act talks about, how you adjourn from your open meeting, you go into the closed, and there's the agenda. You say why you're going into closed, but the agenda. So there are some subtle differences that I noticed in my reading of the policy. So my training is just, how do they line up and what things do we need to know different? I'm not here for a witch hunt. I just want to do a better job of what I'm doing. That's all.
Absolutely. And that's why I would suggest that we receive the report from the ombudsman and ask staff in the same motion to bring back further information to help the board understand the closed meeting procedures.
I'd be willing to make that motion, Mr. Chair.
Okay,
And I would happily second it.
okay. Kayla?
Mr. Chair.
Oh, Dr. Eric, go ahead.
Yeah, thank you, Mr. Chair. Just comment to not to add to it, rather to recap it. I agree with both board members suggesting training. This is what we've been advocating for forever to increase the training and the quality of it. And I agree with Mayor Charbonneau. I didn't say that we're not under the Municipal Act for the board meetings. We are under the Municipal Act for the board meetings, but we are under other act as well. There is opportunity for training. It's built in with our policy, and that's not necessarily related to this item. Rather, it's covering it as well. So I would definitely advise for the board to increase the opportunity for training as much as we can. But we already have that training. It's already recorded. It's already done, and it's scheduled. Related to the details about going into camera or not camera. Again, this is something I would recommend, and we always recommend, the executive committee and myself, that we do it, and it is built in our policy to be done every 2 years, but it should not be done under this item. I'm just trying to separate three routes to do things. One is to review our policies, which is already scheduled for the executive committee. One for training for the board members, whether for the HAPA Act or the Municipal Act, and that is also training is scheduled. And the third route, which is receiving this ombudsman report and announcing it in our meeting, which is exactly what the chair just suggested that we need to proceed with.
Okay, thank you, sir.
We're in agreement.
Yeah, so we have a motion on floor, duly second. Any further discussion on the motion? I'll call the question. All those in favor? That is carried. Thank you very much. Media releases, Dr. Eric.
Thank you,
have to be
Mr.
there.
Chair. I will turn this to Denis.
Oh, Denise, sorry. Sorry, Denise. I didn't even said good morning to you this morning, so I knew you were in the building. Sorry.
Thank you. Thank you, and through you, Mr. Chair. There are 3 media releases on today's agenda. The first, which was issued on February 27th, advised the public that public health had received reports of 3 opioid overdoses, including 1 fatal overdose within a 48-hour period. Fentanyl was the drug believed responsible for 2 of the overdoses, including the fatal overdose. The second media release focused on Nutrition Month, which occurs each March. Public Health has been utilizing its social media channels, as well as this press release, to provide information to the public on tools, recipes, resources available to help residents unlock the potential of food at different ages and stages in life. And finally, Public Health issued a media release on March 8th on our plan to consult with municipalities, businesses, and other stakeholders to ensure full, permanent, and equitable coverage for Public Health Ontario's well water testing program in Grey Bruce. The plan is to establish and service a network of water sample drop-off and pickup sites, replacing and adding to those serviced locally by a PHO courier to make locations available within a 30-minute drive of any household in Grey Bruce. And that concludes the media releases for this agenda.
Thank you, Denise. Any questions regarding or comments regarding any of those? Ken?
Through you, Chair. Thank you for that report. I was listening as you spoke, March being Nutrition Month, and the words you used were ages and stages. And I wondered, actually my question is directed to Dr. Zayed, and the report you gave us last month was about health, ages and stages. And I didn't know, I was wondering how your work in that field, like was that tied to the media release, or was it intentional about this report coming in February because it was leading into March, which is Nutrition Month, or was that a separate initiative that you had chosen? Like they tie together so well. As coincidence is a wonderful thing if it turns out well, but it's not a coincidence. Okay.
It's intentional.
Okay.
I mean, through you, Mr. Chair. This is something that we are taking care of in our planning. What are the events, like the international events and the national events, and how we tie that in with our plans.
Okay, very good. Thank you.
Thank you. Any other questions regarding the media releases? Okay, I entertain a motion to receive them. Kevin, seconded by Ken. Any further discussion? All those in favor? That is carried. Thank you very much. Dr. Aaron, Medical Officer of Health update. Dr. Aaron, please.
Thank you, Mr. Chair. Update on the COVID situation is very brief and positive. All the indicators continue to be favorable, whether it is the number of new cases, number of outbreaks, or people hospitalized. There has been recent communication that we received from different levels in the province, whether it is the Chief Medical Officer of Health office or the biology lab for London, which is part of Ontario Health. Both of them indicate next steps to be dismantling part of the response to COVID and moving it to normal business of public health units. For example, the memo that came from the Chief Medical Officer of Health, March 24th, indicates that the Provincial Case and Contact Management, CCM workforce, will be winding down as of June 30, 2023. And the Provincial Testing and Isolation Information Line staffed by the provincial workforce will also be discontinued. And this is very reassuring that we're on the path to having this pandemic behind us in the near future, hopefully. That's my update, Mr. Chair, and open to questions as always.
Okay, thank you, sir. Any questions for Dr. Aaron? Not seeing any. Motion to receive his update. Sue, seconded by Luke. All those in favor? That is carried. Thank you. Corporate services. I see the two items are reversed in the binder. Which one would we like to do first, Kaylee?
Oh, I see what you're saying. Kim's on her way now. So I'll allow her because she's going to speak to both items.
Okay, good. All right. So we're just waiting for Kim to arrive.
Who's taken? I assume the calendar hasn't informed them, they did that appointment yet.
Okay.
Sorry.
No, that's fine. I'm just waiting for Kim.
She could have been here last week.
She could have done. Sue's appointment. This is appointments, almost ending.
Yeah.
My apologies. Intern chair, vice chair. For my tardiness. But potholes in conversation with the gentleman that was blocking my driveway, I'm getting out this morning.
Well, it's always informative to have interactions with constituents.
Yeah.
Mr. Chair,
Yes, Dr. Eric.
on the agenda, there is a standing item for the opiate situation in Grey Bruce with Dr. Zayed. I wonder if you intentionally skipped over it or you would like to cover it.
I did not intentionally skip over that. I apologize. Now we need to wait for Kaylee to come back because we haven't got a recording secretary. So we'll come back to that in just a moment. Thank you, Dr. Eric. My apologies.
Everyone's very busy at work here, so I stood aside. Get somebody to stay there.
Everything else, I apologize. I skipped over these updates. So now that we have Kaylee back, we'll receive Dr. Zayed. Please.
Through you, Mr. Chair, for the update, as you all heard about the 5 overdose in this month, and it was only in the last few days of the month, around 27th of March. Unfortunately, 2 of these cases have been were fatal, and they are the 5 cases were in Owen Sound, and again, we are trying to do more. We work through now working more focusing on the collateral data, meaning collaboration with the police and collaboration with social service and FOS to know more about the situation, about the circumstances of these cases in detail, so that we can try to have more target knowledge education, not like the widespread education is good, but the targeted for certain patterns is also important. On the positive side, still I have to say that the SOS team working collaboratively with public health is doing a great job on the local level, like trying also to dismantle these complex issues related to socio-economic circumstances, and as we have been mentioning before, that this is not an easy situation that can be solved on a short-term basis, and we are now having more data and more grasp on situation than before. So hopefully on a long-term long-term basis, we can have more focus on that issue, or more resolution of that issue. On the other side, on the harm reduction and side, on the prevention side, the LDCP project, locally driven prevention project, is going very well. We have surveyed public health units, in addition to comparison with the literature review about the preventive programs and the risk and protective factors. I would say now in the mid of this project, the results are like very enlightening. and help, and the final report in June will be very helpful for this protective and risk factor recommendations and the preventive program focusing on the youth.
Thank you, Dr. Zayed. Any questions or discussion regarding Luke?
Yeah, thank you, Mr. Chair. I just wondering, actually, of late, at least in Bruce County, we've been receiving updates about the community safety and well-being plan program, and the collaborative tables that they have functioning, in which I expect are specifically designed to deal with issues like this. In many ways, I just wonder, can you speak to whether that program's having an impact? Is public health involved there? And whether you think that those collaborative tables with all the other agencies are helping to impact this issue?
Yes, through you, Mr. Chair. This is a very good question, and this is what I meant by collateral data, collaboration locally at the local context, transversely. So public health has a very important role in this committee through the chronic disease and injury prevention manager and staff working in this committee, and they have a very good relation with the other committee. In addition to that, of course, there is a poverty committee, home takeover committee, with all the data that we get about home takeover, human trafficking, and the other thing is also the advisory committee of public health for emergent and urgent issues, which have members or representatives from all these committees as well.
Sure. I just wonder, because all of those committees are meeting and all that's happening, but we're seeing a lot of overdoses and some deaths, and it feels like it's increasing and getting worse. I don't know if that's just how it feels or if that's how it actually is.
Yeah.
And I wonder though, so I guess my question, is it working, all those committees and community safety, well-being and all those things? Like, is it actually making a positive difference? Because it does, because when you read the news and when you're out in the community, it doesn't feel like it. So I guess I just wondered from your perspective.
Yes, again, this is an important point. It does work, but as I mentioned, it needs a lot of collaboration now and coordination, so that they have a specific roles, and it is perceived as increasing. But when we have the quarterly data, I feel that we are doing a positive work in terms of mortality. For the overdoses, yes, there is an increase in overdose, but it is successful. And that's why, like successful intervention, that's why we need to really approach that not at a committee level, but as boots on grounds.
Yeah.
And that's what I think the representative of this committee working with the outreach team and coordinating with the outreach team has a very good impact. And I'm seeing this impact is coming on. Thank you.
Thank you, Dr. Zayed. Any other questions regarding that? Oh, Nick, go ahead, please.
Thank you, Mr. Chair. It's been a very hard work week for past couple of weeks, actually, within our communities of Saugeen and Nawash. We've had a lot of people lose their battle to addictions, and hopefully they're at peace now. As I remember our ancestors that are passing on, our elders and grassroots people in our communities are all talking, and we realize that this isn't just hitting our reserves here in Grey and Bruce. It's hitting across Turtle Island, and it's not just affecting our communities, it's affecting our neighboring communities as well. Our people that have lost their lives this past week were young, full of zest, and full of life. It is a system that is broken and is failing us. And I apologize for getting upset and emotional on this, but this is long overdue. We talk about it. We continuously talk about it. Until the hospitals start to change their policies and their attitudes, we are going to continuously see our people die of Grey and Bruce, of this addiction and this opioid crisis that we are in. This is more of a state of emergency than the pandemic, as far as I'm concerned. And I think we need to address it as a state of emergency. Not with just within our First Nations communities, but across Canada, and we need to get the politicians on board to understand this. I don't like to use this term, but we are at war with people that have no morals and no ethics, and their sole purpose in life is to hurt other people. And we need to take a stronger stance at this. And we need to take a stronger stance with our hospitals to get their policies in place, because they just look at this as an addiction, not as a mental health issue, and not looking at this as a whole. I'm going to stop there because, like I said, I'm very emotional about this right now, and I wasn't going to attend today because of everything that we just finished dealing with this week. But people need to realize that this is hurting more and more, and the ones that have been dealing with this for years, we're starting to get tired, and we need help from all of you folks and everybody that's in the government that can make this positive change. And I hope that this opens up people's hearts to understand this and hear it with their hearts and be able to share it with each other. And I'll just thank you for that.
Thank you, Nick. And certainly no need to apologize for being emotional. It is a very, very emotional issue, and your words are well received. Thank you. Any other comments? Ken?
Being through you, Chair, being human is a great thing.
Yep.
So I'm going to tag on to Councillor Charbonneau's comments. Dr. Zayed, if I may, please.
Yep.
I appreciate that frequently our response to any sort of issue is let's form a committee and study it. And I appreciate your comments about, you know, that's a starting place. Boots on the ground are important. So in the midst of all the collaboration, public health, as you play your part, if you are human, you look back and you say, well, that's not going the way we thought it might have. What if you were able to make one significant change to this collaborative approach, and you can dream as big as you want here, whether it's money or people or planes or crews, it doesn't matter. What change would you make to this collaborative effort to maybe more positively affect the outcome?
Thank you for the questions, Mr. Chair. The main change that we are really striving for is a system, to have consistent system, the system that responds to things in a collaborative way where everyone knows their roles. For example, if we are dealing
May I interrupt already, please? I appreciate the comment, but the system frequently is what gets us into trouble. Is it people power? Is it government money? Is it more nurses and doctors on the street? Let's get us down closer to the boots on the ground for me, if you could, please.
What I want to clarify about the system is the capacity, building capacity, and having consistency in funding of certain program that is targeting the main issue that we have, like we did a SWOT analysis,
Yeah.
which is that strengths, opportunities, weakness, and challenges.
Oh.
And through this SWOT analysis, we have certain points. So we need to capitalize on the opportunities and the strengths, and we need to minimize the issue that we have, like to reduce the barriers. One of the things that Kevin mentioned is about the access to service, like the stigma, and in the same time having the funding, the system and capacity. Like I would really, for example, in indigenous reserves, I would make more consistency of funding rather than working on through fund grants, and also have invest in the local capacity. So to have this certification for local health workers from the community, because this have been proved to be really helpful to have personal support workers from the community, and working on the culturally sensitive or competent programs that, for example, elderly camp, where we have the youth to be involved, about self-determination, cultural continuity. All these work together, and it's not really, again, I want to say it is a complex issue, and we need to know that all the players and how that impacts. And I mentioned a bit before about population impact versus personal impact, and how we can make improvement in every tier of this pyramid. So again, coming back to your question, what is needed is capacity, enhanced capacity on the ground, and more of programs that are continuing, so that we know the impact of these programs.
Thank you, Dr. Zayed. Helen Claire.
Thank you, Mr. Chair. It's heartbreaking. I'm not sure that this is within our purview, but I'll put it out through you, Mr. Chair, for perhaps Dr. Ara to respond. Would it be appropriate for us as a board to send a letter to Alpha, requesting Alpha solicit support for a letter to the federal government to ask them to take action at the border to strengthen the border against the influx of drugs and, of course, illegal firearms? These are both things that are coming in. Would that be an appropriate step that we could take? I feel the frustration of Nick, and this is something that I'm personally vested in, this issue. And I feel that there are lots and lots of discrete little groups studying, and this by no means is an impugnment of what happens here at Grey Bruce Health. I'm very aware that each community, whether it's a health unit or a hospital, they all have their rules and they all have their goals, and they're restricted by their mandate. And I do think that a lot is wasted, that if we could somehow, again, speaking to that provincial task force, if somehow we could have a focus, if we could determine the best way, a holistic way that would address everything, and then we could get all these discrete groups, not to have their committees and talk about how they can do their own little bit, but if we could all globally be working towards that end unit, and every area knows which part of that large pie it's responsible for, it would be better. So I'm going to stop there, just in sum, to ask if there's something that we could do to leverage Alpha to communicate with the federal government on the issue of illegal drugs that are primarily coming in across the border. Thank you.
Thank you, Helen Claire. Dr. Ara, do you want to respond?
Certainly, through you, Mr. Chair. The communication to the federal government should happen through the provincial government. So we definitely can communicate with Alpha to call on the province to do so. Nevertheless, we've already achieved more than that. We have direct through the board's communication to the ministry responsible for addiction and mental health. We established that meeting, which is a first small step towards a bigger goal between the local MPPs, local MPs, and the leaders from the two First Nations communities. Since that meeting, I've had personally 3 meetings, one with the chief of staff from the Ministry of Addiction and other meetings with the MPPs. And as a matter of fact, after this meeting at 2 o'clock, I have another meeting related to the same subject. I do believe we need not to choose either or, we need to choose all possible routes. Communication through Alpha has been continuous. Dr. Zayed is leading a group of health units, by virtue leading the portfolio through Alpha and through Public Health Ontario, or through Public Health Ontario to Alpha. We need to do all of these things. I don't think specifically a letter to Alpha would add more weight than a letter to the chief on wage or the letter to the ministry, what we've already done and we established. And it's really important to realize we're all dealing with the opioid crisis, but certain communities are dealing with an emergency level crisis, not just the crisis. The First Nations has a different communities in Grey Bruce have way more magnitude of the negative effect of this crisis to a degree that they declared emergency. What Dr. Zayed mentioned is right on money, that there are certain programs for us available in Grey Bruce as a given for all of us, which is the healthcare system or primary care. In the First Nations community, these services are not available continuously. They are based on a grant. So the people who operated, for example, granularly, if I'm going to go in a granular way to answer Ken's question indirectly, that group of people who are trying to deal with emergency, spending 60–70%, that's what they shared with me anecdotally, of their time on writing grants to ensure the program is not going to expire after a few months. This is not the way it should be done. So again, it's not one answer, it's all of them. I'm sorry to disappoint you, Ken. There isn't one thing that we can do, that we can look back and do. There's always many things. And every time we identify a drug and how we can have an anecdote to it, 3 more drugs are manufactured overseas and they're crossing our border, that there is nothing. Until that border is secured in a certain way, or the route of importation, we're going to be trying to put out a fire that is bigger than what we can. I don't want to point one finger to the federal government and one finger to the healthcare system, or there is no way we can do this other than we actually work on all these things. And I'm very conscious that, you know, the understanding of the issue of public health emergency related to opioid is not just physicians and nurses and boots on the ground. When boots on the ground is described by Dr. Zayed, she's describing the whole array of people who are working on it, including communication, most importantly, communication. And how's this trickled down to the community, how the community is engaged in it. If we're going to simplify it to physicians and nurses, we might be missing the whole story, and we might be creating undue negative effect that we are putting the responsibility on this sliver of the system. So in short, to Helen Claire, we are doing many of these things. We can send something to Alpha to send to the ministry, not directly to the federal government.
Thank you, Dr. Eric. Kevin, and then I'll come to you, Luke.
Thank you, Matt. To you, certainly, Nick, it's way beyond just the community itself. Your community, my community, it's a more, I think, one of my personal opinion of global pandemic, endemic. But to simplify it down, it goes back for centuries. It's a supply and a demand. And to your point, Helen Claire, trying to reduce or constrain the supply, as long as there's a demand there, it's going to be filled somehow, some way. And the bigger problem is, as you reduce the supply of anything that's recreational, you end up with something that is death. How much or where are we on why is the demand? In my mind, it's I just can't fathom why somebody would demand to put something that is way beyond the percentages, your chance of taking this stuff and surviving. I know wisely enough not to play or drink battery acid, but in a lot of these drugs, that's part of what is the formula to make these drugs. And yet there's a demand for it. Are we continually attacking the supply without understanding why there's a demand? And that's probably a large philosophical question that
Come back tomorrow.
come back tomorrow and we'll still be arguing here about it. But I guess I'm looking to you, Dr. Zayed or Dr. Era. Is there something there for the simple fact that, yesterday there was a report to come out with the fentanyl and the opioid overdose. We've got there's hotlines out there now. If you're going to take this stuff, phone the hotline. If you're going to do it by yourself, phone a hotline and somebody will stick with you while you take it. And if you're not responding after a certain time, we'll send 911 to check on you. If you're doing it by yourself, I go, holy,
If I may.
So I'm struggling to find a question in there that
are
somehow.
they doing anything on we're trying to control the supply. What programs or what are we doing out there to understand why there's a demand?
May I respond to that? Just quick,
Anyway.
3 words.
Sure.
Emotional and spiritual need that they have. And that's pretty simplified. It's a human basic thing. There's something in my understanding, and I apologize to the really smart people in here because I'm just a layman, but it's not about my craving for chocolate is nothing to do that it's healthy for me, even if I eat dark chocolate. I'm sorry, I'm way past 3 words, but it is.
Who's counting?
It's not about anything other than trying to fill or heal or replace something that's missing. And if there's pain reduction through this, even for a little while, we'll do it. So it's something way deeper than a vitamin C shortage. It's a deep emotional / spiritual need that's gotta be taken care of. Dr. Zayed?
Through you, Mr. Chair, again, this is a wicked problem. This is how we call it. And it's complex. There is socio-economic factors. There is social determinants of health. If we talk about the indigenous social determinants of health are even different than the social determinants of health, because they are distal, intermediate, and proximal, which have some, the distal one has some issues related to discrimination, stigma, racism, and in that system, and the intermediate related to trauma, historical trauma. There is parenting issues. There is, and that would be on indigenous and non-indigenous. And there is also mental health issues. There is income, which is a big factor. There is the emotional factor, social factors. So a lot of factors playing. That's why, in addition to the income and the housing issue, which is a big one, and again, even solving the housing issue is not just to give house to someone. This person needs skills of life, needs transitional skills. So all of these needs, complex needs, are playing together. That's why we say that the base of this pyramid to make an impact is socioeconomic factors dealing with that. We have programs dealing with that, but again, I don't want to sound pessimistic, or there is no way of about emotion here. It's about realizing the facts and knowing that there is short-term, intermediate, and long-term outcomes. The program, for example, I can give you an example of programs like Healthy Baby, Healthy Children, and Healthy Growth and Development. They have a program in collaboration with Canadian Mental Health Association, dealing with families who have problems with addiction, or one of the family members incarcerated. Like, they have some risk factor, so they know that these families are high risk in terms of having adverse childhood experiences. So they need to tackle or target that over longer time and help them. So there are some risk parameters that we need to address, in addition to universal risk factors. So again, it's not from an academic point of view. I'm talking really about the real life situation and the context that we are living in, and how to address that. Again, it's not something that is easy to do, but we need to do what we need to do through the systems, through the resources, and through being consistent and resilient, like the resilience of the healthcare worker and the people working together in that is very important. Not to lose hope or to be emotional about it. It's more about, of course, empathetic and sympathizing with these people, but to help them and to have outcome. It doesn't come really as a short outcome, unfortunately, but we are persistent on doing that at many levels.
Thank you, Dr. Zayed. It's very clear that your passion for the issues are solid. Helen Claire.
Thank you, Mr. Chair, through you. It's really incumbent on all of us that even when we don't understand, that we accept. Drug addiction is a mental health issue. No child dreams of growing up and becoming a drug addict. And while it is very complicated, the issue is, and while perhaps that first or maybe second time that someone takes drugs is a choice, quickly thereafter, it no longer is. It's not something that we can all understand by having a meeting like this around the table. It takes years and years of experts to get it. It is very complicated. And I respectfully request that we move on. And if there is an interest in this, that we as a board have a side meeting just to talk about this and for us to learn. Thank you, Mr. Chair.
Thank you, Helen Claire. Sorry,
Yeah, that's a better name.
Sorry.
I wish you'd known my parents.
Careful.
I just wanted to ask a brief and very specific question, because Nick had raised his concerns, and I'm sure his community's concerns about access to the healthcare system locally, and concerns about discrimination on that front. And you, Dr. Era, and the chair, and Jerry Glover, the band administrator from Saugeen First Nation, wrote a letter on February 15th to all healthcare partners expressing that concern specifically. And I just wondered if you'd had any response from local health services, or from any of the healthcare partners that you sent that to. If there's any further discussion about, as Nick had a very specific question about policies and to try to address that. I wonder, has there been follow-up from that letter, more discussion? That's obviously a pressing concern for Nick and his community, and obviously for this board, I assume as well. For Dr. Zayed.
Dr. Zayed.
So you, Mr. Chair, I just have one update of information that Grey Goose Health Services, who are really working on the ground as a collaboration. Of course, it's not only them, but they have extension of their program for another year in Sogin and Newash. So that was we knew about that in the last couple of weeks. So at least they have one more year of extension of that work. So this experience also was started in a culturally sensitive way 1 year ago, and it has some again, it will take time, by the way, for people, even if we have this mobile service. So people will come and just take foods or stuff like that, but they don't involve in service before 6 months until you build the trust. So things will take time for that, but it was good really that they have this extension. But again, when I talk about the system, we need that to be, instead of, as Dr. Ara mentioned, people will write for a rationale about why they want to service. Again, now we have more data to support these initiatives. We have decreased mortality, even we have mortality, but over the years, so that will help. But again, they are always requested to write, rationale and write for grants. So just I want to update you on that.
Thank you.
Thank you. Dr. Eric?
Yeah, through you, Mr. Chair, there was one communication from one of the partners responsible for healthcare to the admin for the Saugeen First Nations, the band admin. I don't feel it is in my position to actually comment on that communication. But there was not, other than that communication, there was definitely the appreciation from the First Nation, both communities, specifically from the admin of Saugeen First Nations for sending that letter and co-signing it. But there was not practical application in meetings or change in policy that I have been aware of.
If I could just, Mr. Chair, it seems to be continues to be a pressing concern, obviously, from what Nick said today, and we shouldn't just drop it. I think it's not exactly in our purview, and I understand that you're not saying that you are dropping it. I just think that we should continue to be focused on it. That it's obviously affecting the health and well-being of folks in First Nations in particular, and I guess just state my view that any way that the Board of Health or Public Health can help to overcome whatever is causing that issue, we should do. And I know you'll share that view. So thank you, Mr. Chair.
Thank you.
Through you, Mr. Chair.
Go ahead, Dr. Eric.
Yeah, thank you. Combating stigma is definitely a key issue in the fight against opioids. And we have been doing this, continue to do this. I was specifically answering the question about that specific communication and letter, which is one of many things that we do. I do believe Helen Clare's statement is right on the money. The creep of scope, as a governing body for public health, the details of what healthcare system, which is another system not under our authority, is doing specifically, or the mechanisms of the way the addiction works, whether it's related to the behavior, the attitude under it, or the value system, or the biology of it. All of these things are very valid points, but I just worry that this is not the subject for us in governing. I would look at the next item on the agenda, for example, the budget for public health and how to secure budget for other organizations and how we can advocate to help them, not just for public health, as way more relevant to helping with the opiate than understanding the details. Like Helen Claire said, this is not just an expert area, it's a set of experts. Like there will be teams, and each one of them will be expert in what they do. And we know what we do in public health, but again, psychiatry is totally different area, and their team will work with our team. There's no way to cover the details of those in a board meeting.
Thank you, sir. Okay, I think we should move on here, unless there's any further comment. Okay, not seeing any. Thank you, both Dr. Zayed and Dr. Eric, for your response. Kim, welcome to our board meeting. You are going to speak to both the annual audit planning letter and the draft budget. So the floor is yours.
All right. So for you, Mr. Chair, we'll start with the draft budget.
Okay.
Today. I'm sure. We want to reaction. I can do that. Okay, so just a quick look at the key assumptions that went into building the 2023 budget. So we've assumed that the ministry will continue to apply the 70-30 funding ratio to the jointly funded programs. So the province covers 70% of our mandatory program costs, and the counties currently cover 30% of that. So we're assuming that's going to maintain the same for 2023. We're looking for approval for a 2.5% increase from both the ministry's contributions as well as the county's contributions for this year. We based our staffing levels on our existing permanent full-time staff, and we also factored in any of the temporary contracts that we have in place and their current end dates. So those have all been factored in. One of the largest variances in our 2022 budget and actuals was the overtime. So it was pretty much throughout the whole year, the amount we budgeted for overtime was significantly less than what we needed. So we've removed the overtime from the 2023 budget to hopefully have our actuals and budget be more aligned throughout the year. We've assumed that COVID-19 and COVID vaccine will be ongoing throughout 2023. So for all members of our infectious disease team, as well as our vaccine team, pretty much all the employees on those teams are working partly in those programs still. And we've assumed that that work's going to continue throughout 2023. And at the time for that work will be covered under COVID extraordinary costs that the ministry said will be available to us this year. We have 3 collective agreements as well as a non-union group. So all of those, or 2 of them, need to be negotiated this year. So we have built in an estimated increase into the budget for what would possibly be the settlements of those contracts this year. The ministry has confirmed that mitigation funding will be continued so that the additional funding, so when the province changed the funding ratio from 75-25 to 70-30, there was $1 million impact to the counties on that. But the province has continued to pay that $1 million impact, and they've confirmed that they'll do that again for 2023. So that's reflected in these numbers as well. And that our benefits will remain at our most recent renewal correspondence rate. So we got prices from our brokers for what we can expect for 2023. So those have all been factored in as well. So just a quick note on how we built the budget. So we start with a preliminary budget in the fall. So we take all of our staffs and staffing and benefits are the bulk of our costs. We start there with our current team, and we build a high level budget based on last year's operating costs to kind of see where we're sitting financially and what we might need from a percent increase or where we might have to trim in order to balance the budget. From there, we get the allocations from all the management on where they want their staff and their teams assigned into which programs, and each manager also builds a detailed itemized budget for each of their programs. That gets reviewed by senior management, rolled up, and then we see financially where we're sitting, and we make adjustments and tweaks and hiring decisions based on that information. And then we bring that final product here to present to you for approval.
So at a very high level, the total funding and total expenses for this year is $17.8 million. So it's about a 10% decrease over what we had for our budget last year. Again, mostly because we're expecting the COVID vaccine and COVID-19 costs to continue to go down, as there's still work there, but not to the same extent that we were forecasting in 2022. So for Grey and Bruce County, their funding share. So in 2017, Grey and Bruce County entered into agreements stating that they wanted to use population data published by Statistics Canada to determine their portion of the cost share programs. So Statistics Canada released an updated census in February 2022. So those are the numbers that we're currently using to determine the breakdown between the two counties. So of the 30% portion that the counties cover, Grey picks up 58.35% of that, and Bruce covers 41.65% of that.
We're in favor.
Okay.
We're in favor of that breakdown.
Don't matter.
So for the summary of the cost share programs, that's our mandatory programs for 2023. This would be the 70-30 breakdown between the Ministry of Health and the county. So 9.3 million from the Ministry of Health, and then the county contribution, which includes that million that is actually coming from the province this year, is just over $4 million. And so I guess if you were wanting to get what does 2.5% look like from the county? So what are we asking the counties for? It would be the far right column. So the 57,000 from Grey County and the 40,000 from Bruce would be the additional funding that we'd be asking from them to make the 2.5% to cover their portion of the 2% increase for the year. We did want to note, so when you submit to the ministry, so we're submitting the ministry and we're asking for 2.5%. If they come back and say we're only going to give you 2%, then there would be an additional 0.5% that we would, have to have the counties cover. So then there is the possibility that 97,000 could be a bit higher, depending on whether or not the province covers their 2.5% portion that we're requesting this year. Just giving a bit of history on our budget from the last few years. So since 2016, when we've come to the board, we haven't asked for any increase from the counties. So we've been, operating within the funding that has been allotted. Part of that is the province has said they're not going to give us any growth funding, so don't even ask. So that's part of the reason. And also, we've had COVID funding and we've been trying to operate smartly and within our means. In 2018, as well as last year, even though we didn't ask for it, the province did provide growth funding to public health. So they gave 2% in 2018. We brought that back to the board, and the board approved that the counties would contribute their 30% of that 2% growth funding. As well as last year, we didn't ask for anything, but they gave us 1% growth, and the board approved for us to keep that as well. So this is really the first year since 2015 that we're feeling we're feeling that the financial increase has not really kept up with the pace of costs, and so that's why we're bringing the request for the increased funding to this budget presentation. So a breakdown of our funding. So the Ministry of Health cost shared is about 53% of our budget. So that's our mandatory programs. And as I said, that's the programs that are cost shared with the counties and the Ministry of Health. Our Ministry of Health 100% funded programs, that's the seniors dental program, as well as the NOH compensation initiative. So the ministry covers 100% of those costs. The one-time funding for 1.7 million, that includes our COVID extraordinary costs for COVID-19 and COVID vaccine, as well as the school focused nurse initiative, which was something that started at the beginning of the pandemic to hire additional nurses for the schools, and the IPAC Hub funding that we're assuming will continue again into 2023. The funding for the other government agencies, so that's our Healthy Babies, Healthy Children program, it's just over $1 million. as well as our Health Canada Children's Oral Health Initiative for about 100,000. So those are the two main other government agencies. Interest, donations, and miscellaneous income. Most of that is interest income that we're anticipating for this year. And direct from client are reimbursable vaccines, so MenC, HPV, flu. We're hoping to have some OHIP billing this year, and for seniors dental, sometimes there's a cost shared piece of the services they receive, so that's that we go into the direct from client category. For our 2023 budgeted expenses, so salaries and benefits continue to be our largest expense. They make up 77% of our budget. This is down 11% from last year, mostly due to removing the overtime from the wage lines, and that's being offset by wage increases as well as increased benefit costs. Our occupancy costs make up 9% of our budget. So this is the cost associated with covering our mortgage costs, the utilities, external rent for our dental clinics, as well as our facilities team. So this budget was increased 1% this year with the increased wages for the facility team and the addition of the new Walkerton Dental Clinic location. Professional services is 5% of our budget. This includes audit, legal, negotiation, dentist fees, and purchase services. So purchase services would be things like privacy support and the security at the vaccine clinics. Staff training and travel is down about 4% from the prior year. So a lot of managers adjusted their budgets this year to reflect a lot of training is now done virtually. So we don't need the accommodation budget lines that we have had historically. And travel is also down with staff not traveling to the mass immunization clinics every day like they were at the start of 2022. But the CRA rate did increase their per kilometer rate allowance. So some of the savings will be offset by that increase. IT and telecom, we're doing some significant upgrades to our IT environment right now. We're moving to cloud-based systems. And so IT is budgeted for those projects and licenses required for that. And we're looking at modifying some of our cell phones, structure and phone lines so we can see cost savings in those lines. And then the other operating line includes the main one there is our insurance, which is pretty substantial. Our associations and memberships, our board expenses, media and furniture and equipment. Looking at our staffing breakdown. So, you know, we pretty much kept the program staff the same. We've had some changes to the positions that we have in the administration area, as well as our management FTEs. So in 2022, we did hire some additional managers to take on the COVID school nurses, as well as the COVID vaccine program. So we added manager positions last year, and this year we're kind of going back to our regular structure, which is why it looks like there's the decrease. And for the program supports, we've added some additional program assistants and some vaccine delivery FTEs to that line. Part of our request to the ministry, we also are allowed to submit one-time funding requests. So for 2023, our COVID-19 and COVID vaccine request is just over $1 million. We're looking at asking for a new vaccine fridge. We have some that are quite old and we don't want to risk failure of losing vaccine from a fridge malfunction. So we'd like to replace a fridge. The PHI student practicum is something that we've done most years. It's a good opportunity to mentor a PHI and also to develop a pool of PHIs that possibly could come work for the organization. There's the inspector reporting system that they're using. They're looking to make a change to a new system. So this would be a one-time software implementation request. We're looking to hire an additional inspector to help with some of the recovery and catch up that the PHIs are looking to do over the summer. And then for the Walkerton Clinic, the funding approved one dental chair, but we have 2 operatories. And so we'd like to have 2 dental chairs ideally so that we can see more people. So we've put in a request for that chair. And something that doesn't go to the ministry, but is also part of our annual budget is our capital fund. So the capital fund for 2023 includes the continued rent from the Ministry of Environment. So they lease a wing on the 3rd floor of our building. We have interest income that we're earning on the fund balance. There will be 4 mortgage payments made quarterly. And the capital reserve fund study that we have completed identified that we may have to refurbish the metal panels of the clad exterior as well. So we've included the amount identified in that report in this budget for the year. And that's it.
Thank you, Kim. Very good report. Questions, Kevin?
How many more years in mortgage?
Quite a few. So they were both 20.
Okay.
They're both 25 years, but they wouldn't have been paid off by that time. There would still be a balance left after that.
The interest on just what percentage you're using with bank interest going up? We're not using the 2021 interest of 0.5% on any of those capital.
It's tied to prime. So as the interest rates go up, the interest rate that we're earning also goes up.
Okay. And there's a. They wrote it down here. I think that I thought I did. Apparently you didn't. Maybe I didn't. I'll go on to somebody else. There, and I keep looking here to see where I was at.
Any other questions from anyone? Ken?
Thank you, Kim. That's quick and easy budgeting. Well done. So I have a couple of questions. First off, just for my education here. I would listen to your comment about our board's request to the province. And if the province says we only get 2%, then the other amount has to come from their counties. Is that a expectation? Is that part of our terms of reference? Like I just heard if they don't pay it, you have to. So I'm just wondering what the obligations are that are included in there.
Yeah, through you, Mr. Chair. So there is language in the Health Protection and Promotion Act, essentially saying if the Board of Health pay or spends over if the board spends the provincial allotment and then you exceed it, then the obligated municipalities would pick up the difference. So it's in the act.
Through you, Mr. Chair. So what I just heard you say was, if you have your budget established and we overpay, then the board has to pick it up to the counties. Okay, I understand that, but we haven't got an established budget. We have a request that you're going to submit to the province. So the second half of the question becomes, if the province says no and the county say, just let me do some thinking here just a moment. What programs are on the cusp? What activities within the public health are at risk if province and county say, no, we're not doing that this year?
Dr. Earl wants to jump in there if you don't mind, Kevin. Go ahead, Dr.
Oh,
thank
come
you,
on,
Mr.
that's
Chair.
not fair.
Thank you, Mr. Chair. Sorry, I thought the question ended, the connection probably slowed down on my end. So the Health Promotion Protection Act stated clearly, using the word shall, which is a higher burden than will or must, that the obliged municipalities will pick up the difference. There's no option there. It's not a request, it is the law. And the reason for my understanding from my studies about the act being worded that way, that public health services should not be at jeopardy because of funding. But there is details of this in the orientation for the Board of Health, the annual orientation.
Thank you, sir. So the short answer is we're on the hook.
So you can present a budget of any amount and say, there you go.
We have to approve it.
Well, we have to approve it, but if we don't approve it, what happens then? But like the only way that if we're governing here, says, you know, we will, absolutely, I respect it, but if somewhere along the line we don't approve it because they've asked for 49% increase, you've asked for 2.5, and if that doesn't happen, what are the net effects on public health? Like, what is it? Healthy babies, healthy families? Is it COVID programs? What's might I ask? What's first on the endangered list here? Is that a fair question?
I would just say that's up to the board, right? The board sets the priorities.
Well, but that makes the recommendation to coming back at 4. So, and you're absolutely right. We do make the decision. Absolutely, but and I'm not fussy about saying no, that's not what I'm saying, but you gotta have things prioritized, and I would like to know, just for information, like, what is it a nick off everything, or is it, no, this is something we wanted to start, but now we can't, or how does your management team address that issue? What happens if we can't get all this money?
Dr. Eric?
No.
Yeah, thank you, Mr. Chair. So there are 2 items there in the question itself. The second one is easier to answer, which is the business continuity plan. The term business continuity plan says if there is emergency and our resources are exhausted or imminently exhausted, what programs need to be delayed or can be delayed. For example, a rabies vaccine is life-threatening, will be categorized as A and will still in function no matter what. And during the pandemic, the COVID-19 pandemic, it continued to be, versus smoking prevention, for example. That's educational and can be delayed for a number of months for us to catch up with the indicators. I would shy away from naming the different programs because our staff are listening to this discussion, and is it going to be perceived that my job is less important than other jobs? Or nevertheless, that's a second part. There is a business continuity plan. It's part of the emergency binder. It's available for board members. We can go through it at the scheduled emergency presentation, or at any different time. We can tailor it for different board members if they're interested. So that's one part of the question. The second one is if we approve it, or I really hope that everybody around the table knows that there are members of the Board of Health. They're not wearing their municipal hat, and that's part of the governance of public health. People who come to the table, they're serving Grey Bruce. They're not serving their own municipality in those meetings. So again, what would happen that when the Board of Health does not approve its own budget? I think there are multiple scenarios to it, but none of them is really related to good accountability. So we need to worry about the Board of Health budget, and the county will worry about its own budget. The ministry will worry about its own budget. And again, I would not recommend not approving a budget. We can definitely bring different budgets or different things that we can propose, but this is a proposal at the table. We'll be more than happy to walk the board through what's needed there.
Thanks, sir. Okay. Thank you. I appreciated within the senior management team, there are essentials and there's priorities on the list, and there's things that can be amended and adjusted. That's good management. Thank you. Okay, good. Any other questions? Oh, Kevin, I'll go too, and then
I did find it.
You did.
I knew I
That's
was.
good. That's good.
During a presentation, Kim, you said that the COVID-19 and the COVID vaccine, we had shifted or kind of upscaled to meet that, and it's still being put in there. Research will tell us that the next pandemic is just around the corner. So should this, instead of being perceived as being left in, I guess I've been around long enough that it was kind of with the Board of Health when SARS was here. And I remember Dr. Lynn saying at that time, this is a big wake up to us. We haven't had one for quite a while, but they're going to come. And I'll always remember saying that this, we better be prepared because the next one is just around the corner. Well, it took us what? 15, 16 years from SARS to COVID. But the focus is, you know, it took us 100 years from the Spanish flu to SARS. But the thought is, I guess, should we be more cognizant of having this permanently a pandemic sector or whatever in public health to meet the next pandemic instead of saying, yeah, but this may be a permanent part of our budget going forward. That's my question.
I didn't understand it, but maybe Kim did.
Mr. Chair,
And you
so
weren't supposed to be. Thank you, Mr. Chair. Good.
I agree, and I think a lot of that's what we're seeing in public health units that are, you know, who haven't been asking for anything. We're identifying that we need this additional funding, additional people permanently, because this work isn't going away. It's going to be there long term. And so if we're frozen at zero, how can we continue to respond and have that additional capacity? With everything else going up, if you know, even with inflation, we're actually losing capacity.
Correct.
So I think that's why you're seeing, you know, health units asking for, you know, I kind of canvassed them, you know, 2%, 3.5%, 4%, one asked for 22%. So I think we're all recognizing that there's a lot more work there than there was. And then, yes, this extraordinary funding is a bit of a Band-Aid, but once it goes away, we know that all the work isn't going away and we still need those extra people. And so this is kind of our way of, it doesn't fully cover everything, but it does get us closer to achieving that than if we don't have any growth funding.
Okay.
Good, thank you. Luke?
Yeah, that triggers another question for me. One simple question to start, and I'm sure there's a simple answer to it, and I just don't know it, but the our rental income from the Ministry of the Environment is frozen year over year. I assume we have an agreement with them that doesn't allow us to increase the rents. Is that the reason why it doesn't increase?
Through you, Mr. Chair, that's correct. So the last agreement that was entered, it was at the same amount year over year. It does renew at the beginning of 2024. So there would be the opportunity to renegotiate these costs at that time.
Well, we should actually do that. I mean, there's our costs, inflation just this year is 6.5%, and that's, as a landlord, that just means this is worth less and less money every year. So there's no way that we should sign a new agreement that doesn't include a escalator, a CPI escalator. So anyway, thanks for that. And then I guess just to follow up on Kevin's question, because it's a good one, and the Chief Medical Officer of Health report really puts a clear point on why that money is necessary. And you know, Kevin, there's been a pandemic. What is there, like 20 pandemics in the last 100 years, according to the chart in his report? So we need that funding clearly, but we're asking for one-time funding and we're calling it COVID-19 funding. But I just wonder if we should be calling it pandemic readiness funding. It's not really, okay. If our hope is for it to become permanent, we should say to the ministry, we should be positioning it in some way to say, you know, you can call it one time this year if you want, but we're going to ask for it one time every year. And it's not COVID-19 response money. It is now transitioning to pandemic response funding. I don't know if that matters in the ministry's, you know, if we can communicate that to the ministry through the budget or not, but I just feel like we should be calling it pandemic readiness funding, and we should be positioning it in that way in this budget rather than this COVID-19 funding.
Something a little more permanent too.
Well, that's what it is. And then we could just send them this chart that came from the CMOH. It says we have to be able to respond. These happen. Well, now, and just in the last decade, there's been 10, right? So we need this funding all the time, right? Anyway, I don't know. Thank you.
Thank you. Luke, Kim, did you want to respond or?
Sure, through you, Mr. Chair. We could certainly, I think to do what you're suggesting would probably require we send a correspondence with our budget. The naming conventions and the format of the request is all kind of dictated to us from the ministry and what they've called and what they've classified it as. But we can certainly, submit it and tell them, like, this is the task, this is what the request truly reflects, we could include that with our submission.
Thank you, Richard, so to speak. Dr. Zaya.
Through you, Mr. Chair, we have also part of the plan, the annual service plan, emergency preparedness. So this context can be articulated or is articulated in that part as well.
That would be good, Mr. Chair. I think that, when something is recurring consistently, it can almost hardly be called an emergency. It's really, it's part of our operations, right? So I think a letter would be a good idea, either from the medical officer of health or the chair or both, to put that in context and say, we believe this funding is permanently required as pandemic preparedness money. I think that communication in connection to the budget would be a good thing to do. So I certainly hope we could do that. Sure. Thank you, Chair.
Yep. Any other questions regarding the draft budget? Helen Claire.
Thank you. Just in relation to my colleagues earlier addressing of adding a line item for future pandemics, I'm just wondering, because of the imperative language of shall, does that mean that if we have a line item that then adds a bucket for a permanent bucket for future pandemics, should the province say, no, we can't come up with that, will that increase the levy on each of the counties? Thank you.
Yeah.
So through you, Mr. Chair. So yeah, if you built your budget, for $15 million, assuming that the province is going to pick up, 10 of that, and they only pick up 8 of it, then yeah, you would have to find that extra $2 million through the counties.
Thank you.
Okay. So Kim, just to be clear, are you looking for a motion to approve the budget, or is this just a draft for now?
Through you, Mr. Chair, I'm looking for approval
Okay.
of the draft budget.
Okay. Luke?
Don't move.
Okay, second, Kevin, any further discussion? All those in favor? That is carried. Thank you, Kim. You're going to speak to the planning letter or the audit planning letter as well,
Yes.
please.
Okay. So through you, Mr. Chair, we received the annual audit planning report from BDO, who are our auditors for the 2022 fiscal year. It's a standard report that they send out at the start of every audit year. It outlines the responsibilities of Grey Goose Public Health during the audit. And it outlines what BDO's responsibilities are during the course of the audit. It identifies the areas that they think that there's the highest risk. So they will develop their tests and processes around those areas that they think are higher risk to get the audit assurance that they need. And they've also identified what the materiality will be. So kind of the higher threshold that they're looking at that they'll be testing. So I'm not sure if there's any questions about the report, but it's just kind of an annual update provided from the auditors.
Okay, thank you. Any questions regarding the audit update letter? Kevin?
Not really maybe connected as much to the letter. BDO is under a 5-year contract with us to do the audit. Usually it's 3.
Through Mr. Chair, it was a 3-year contract.
And it'll be up 2024.
We just went to market with it last year, so it'll be 2025.
2025. Okay.
Okay.
Yeah.
Do we require, I think we do require a motion to receive this. Yes, we do. Sue makes that motion. Ken seconds. Any further discussion? All those in favor? That is carried. I'm thinking let's just finish off the other business and then we'll take a break before we go into camera. The other item there is the June 2023 Alpha AGM and conference, which was being held or is being held June 13th of this year. I don't know if I don't think anybody's necessarily speaking to that. Are there any questions regarding that other business? I see there's a call for Board of Health nominations, the Alpha Board of Directors. If anyone is so interested, there's a information and the nomination form is there for your information. So seeing no other, oh, Kevin, go ahead.
But in my understanding, we as being Grey Goose wouldn't be eligible for somebody to go onto the board.
I have no idea. I just assumed we would be, but maybe we're not. Why would we not?
No, I think, well, in my reading, and if I'm not mistaken, it's the Northwest region, the Central East and the Northeast, which is.
Oh, I see. Right.
We're not.
One of us.
Right, because they cycle through. Right, okay. Very good
Yeah.
point.
Phenomenal.
Okay, so we're not eligible this go around. Very good. All right. I'm gonna suggest we recess for 5 minutes and then we'll come back and do our in-camera session. Ken?
So I'd like to move that we move into camera for the list of reasons listed here. And upon after the recess.
Yes.
But one of the things the ombudsman identified was the resolution about going into, and upon completion, we return to open session.
Correct.
So I'm just asking that a resolution be offered directing us to go into open session for the reasons stated in the agenda,
In closed session.
in the closed session.
Yeah.
And upon
Pleading that-
completion, returning to open session.
Absolutely. Yep. All right, let's recess until, well, for 5 minutes. The motion is to go in camera to discuss 3 items. First is the adoption of the in-camera minutes from February 13th of this year, February 22nd, and March 3rd of this year. So the 3 items there. Three sets of minutes. The second item is personal matters about an identifiable individual, including municipal or local board employees. And that is a review of a document received about an identified individual. That is a verbal update. And the third item is litigation or potential litigation, including matters before administrative tribunals affecting the municipality or local board. And the item is an update on a verbal update on potential litigation against external parties. Would someone care to make that motion? Kevin has moved that. Is there a seconder? Luke? All those in favor? That is carried. Okay, we are now in closed. Good to go? Okay, thank you, Kaylee. We are now back in open session and I can confirm as chair that we only discussed those items on the in-camera agenda and there was nothing to report of. I need one more motion to adjourn. Chris and Helen Claire, all those in favor? That is carried. Thank you, everyone.
Okay, bye, everyone.
Thank
See you guys.
you. Bye.
Yeah, Chris.
Have a safe drive home in the freezing rain.
Thank you. Oh, we'll enjoy our lunch here until it starts to really rain.
We'll just spend the night, eh?
No,
We do have that.
let me